Okay, good evening, everyone. Thank you for joining us once again for our Friday webinar series. Today's webinar is on inhibitors, coping during COVID-19. My name is Brett Spitali, and I'm the Vice President of Advancement here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to the panel after the presentation. This webinar is being recorded and will be available to the community beginning on Monday, June 1st. I would like to introduce our panelists this evening. Dr. Len Valentino is the President and CEO of the National Hemophilia Foundation. Dr. Tami Singleton of the Mississippi Center for Advanced Medicine and Director of the HTC. And Dr. Tyler Buckner of the Hemophilia and Thrombosis Center of the University of Colorado and Director of HTC Clinical Research Program. We thank them for taking the time to join us, and I'll now turn it over to Dr. Valentino to get us started. Len?
Thank you, Brett, and good evening and good afternoon to our guests from the West Coast. As part of our Friday webinars dealing with COVID-19 and issues that are important to the inherited bleeding disorders community, I'm really pleased to have two excellent speakers with us this afternoon, Dr. Tami Singleton and Dr. Tyler Buckner, who are going to talk about the implications of COVID-19 in the inherited bleeding disorders community with special reference to the inhibitor population. We know that this is a very important topic and we'll take you through, I think, some of the major issues that you're all thinking about and hopefully provide some questions and a sense of security for you during this challenging time. So without further ado, I'd like to turn it over to Tami and Tyler. Thank you.
Thanks, Dr. Valentino, and welcome everybody. Thanks for attending. So I'm Tyler Buckner from Colorado. So tonight we're going to go through just some updates, and really we've tried to format this in a way that just asks questions that we think are commonly out there, that we hear a lot, that we ask ourselves. And so we'll go through some general questions in the beginning and so a little bit of background information, and then talk about questions that are relevant to those who are living with inherited bleeding disorder, and then move on to questions that are really more specific to those who happen to have an inhibitor. Next slide. So first I want to talk about situational awareness, and what I mean by that is really your efforts and our efforts to stay up to date with what's happening with the COVID-19 situation. We've been at this now we're at the end of the 11th week at least since my institution shut down its normal operations. And so we're kind of getting used to this, but I can tell you that we as a hemophilia center meet twice a day to talk about what's going on and what issues our patients are having and our staff are encountering with all the different efforts going on. And then at a larger level, we meet twice a week to discuss COVID-19 in general. So we really try to stay up to date to try to answer these kind of questions. What's going on with COVID-19 worldwide, as well as where I live. I will point you toward some sources of information that are reliable. And hopefully that is helpful. So next slide. So here's two important examples of reliable information. So I'd like to start broadly by looking, at the worldwide data, and then hone in down on the country, and then even further into the state, to our local areas. So really, for that kind of worldwide data, one of the more helpful sites is the Johns Hopkins Resource Center, which I'll show you some screenshots in the next few slides. And there's a link to that there. And then each of you likely have a public health department for your state that is keeping up with data related to COVID-19. And in many cases, they publish those data. For instance, in Colorado, which we'll look at one example graph from our state, they update the COVID numbers every day at 4 p.m. and have been for almost 3 months now. Next slide. This is the Johns Hopkins site as of yesterday afternoon. This is updated continuously, and you'll see the numbers kind of counting upward. This slide is, again, these are worldwide numbers, and not included here to create any kind of fear, but really to just point out a good way to stay informed and up to date. And well, you know, one of the things that kind of jumps out is the total number of cases there on the left side of the screen. The total confirmed cases worldwide as of yesterday sits at 5.9 million. And then you can see in red across the world where those cases have been reported. An important thing to keep in mind is that the number of confirmed cases does depend on the availability of testing in many cases, and so that may affect the way that this map looks. But it's really the best data that we have to try to understand what's going on. Next slide. So we're going to focus in on the graph that was on the bottom right of the first screen, and this is just to show you that you really can drill down and look at how things have progressed over time. On the left is the number of confirmed COVID-19 cases across the world since January, and that graph that's kind of going up and to the right is the increasing number of cases total, and you can see that started to really take off in March and has really increased at a very steady rate since that began. That's further illustrated on the right. Those are the daily reported cases from around the world, and you can see that by late March we kind of reached a plateau of about 100,000, 80 to 100,000 cases being reported every day since then, and it hasn't changed a lot. So that's important to know. On the other hand, we all know that the situation is very much a local phenomenon, and so drilling down into smaller and smaller geographical regions is the next step. So we've seen the world data, and then on the next slide, this is the United States, obviously, and these are the counties that you see colored in here. This happens to be per capita confirmed cases. So it's the number of cases per person in each of these counties. And there are some hotspots around the country and on the East Coast and around New York City. It's one that many of us know about, but also the Deep South has been affected, as well as some of the reservations out in the West. And then my state around where I live in Colorado is also one of the areas of higher incidence here. So this is a big overview of the country. And then the next slide is just a quick example of the Colorado data. And again, these are helpful because it gives us a sense that while the cases kind of took off in mid-March, it does appear that they peaked, at least where I am, in late April, and we've kind of had a slow but steady decline since then. That being said, we're still seeing about 200 new cases being reported per day. Again, we know that these numbers are very dependent on the availability of testing, which is only in the last several weeks become widely available, but they are helpful for us to see what the trends are and have a sense of where things are headed. The message that's been given over and over and over as we've moved through these days over the last 11 weeks has been, we're not sure what this means, but we're keeping a close eye on it. And that's really what is continuing to happen. So this is situational awareness and having a sense of what's going on out there and what we're up against. I'm going to turn it over to Tami, I believe, at this point.
Absolutely, absolutely. Thanks again. It's so nice to be here with everybody, Dr. Valentino, everybody else out there with NHF, Tyler, all you guys. Thank you so much for having me here this evening. I think this is such an important topic to talk about. And just this evening, I was with my family and we were having dinner, and sort of the title here, we all discussed like, what happened? Right? Like what's going on? How did we get here? And we even joked and said, can we have a 2020 do-over? Can we restart this whole thing? Well, I think there are a few important facts that are important to understand what's happening. So hang in with me and let's just kind of wrap our minds around what exactly happened. So as a physician, I'm very familiar with coronavirus. It's not a new phenomenon. It is something that I'm very familiar with. I understand the different types of infections that it may cause, but the average person really doesn't know or didn't hear anything about coronavirus at all until recently. The fact is that most of us will be infected with coronavirus of some variety at least once in our lifetime. And so most of us, again, have only heard it in terms of the type of coronavirus that's causing our COVID-19. It's actually called SARS-CoV-2. We've never heard of this before, but it's a virus that's a part of a family of viruses, hundreds of viruses. Typically, this kind of virus, this family of viruses, would affect animals, but it certainly can spill over, if you will, into humans. And so coronaviruses absolutely have the ability, as we now know, to cause disease in humans. Most, I want to point out, most coronaviruses, around, again, the ones that myself and Tyler are familiar with, most of those viruses can cause really mild disease, but a few of those can certainly, as we now understand, can cause more serious and even fatal disease. So I thought it was important to kind of frame that in terms of what happened and what are we talking about. Let's take a look at the next information. So what commonly happens with coronavirus? So coronavirus can be found all over the world and is really responsible for about 10 to 15% of all common colds, primarily during the wintertime. But again, not all coronaviruses cause mild disease, right? So we do have some historically that we're familiar with. I'll take you guys back to 2002, right? So 2002, I'm sure that you're familiar with or remember SARS, right? So SARS was detected in 2002. The last case was noted in 2014, and not more than 800 people died of SARS. SARS, however, was a little different. I think is important to highlight right now. SARS that we knew in 2002 presented with very severe symptoms up front. So it was very obvious when someone presented with that form of coronavirus. So, for example, in China, which was at the time a huge epicenter of SARS, and they were at significant risk and danger because there was such a huge population, they pounced and clamped down on anyone who had severe symptoms and contained that disease process so it would not spread any further. Again, at the time, that was much easier to contain because the symptoms were very obvious, very sudden, and very severe. There was also another outbreak that was similar in 2012. It was a Mediterranean version of SARS. So having a coronavirus that can cause overwhelming infection that can ultimately lead to death is rare, but we certainly know it has occurred in kind of pandemic form in the past. So let's take a look at the next slide. So again, I think this is a big question for us, especially for us here in the United States, because as Tyler pointed out, there are places in the United States that are seeing a lot of documented cases, and there are other places where we're not really seeing as many documented cases. And I'm emphasizing the word documented cases because we only know if someone has it if we're actually testing people that have it, number one. And number two, the symptoms in terms of how you present if you're infected with coronavirus and then can pass it on to someone else, that's totally different from the other forms of coronavirus that we've seen in the past. So is this really happening? Yes, it is. And we have the data that he just presented to sort of back that up. Here's something else that's really important about coronavirus. Let's take a look at the next slide. So it's not just happening on TV, but here's the challenge. The main challenge with COVID-19 is that the symptoms, unlike SARS in 2002, that horrible outbreak where we had almost 1,000 people to pass away, and the symptoms were very sudden and very severe. With COVID-19, some people may be infected and show no symptoms at all. And therein lies the danger, because those people can still infect other people. That's why it's kind of hard to wrap your head around this. So I want to emphasize that part again. There are some people that are infected with COVID-19, this form of coronavirus, and the symptoms are very, very mild. They may not show any symptoms at all, but can still infect other people. In fact, we have some estimations that a single person who may have very minimal symptoms or almost none at all could infect up to 5 other people. So that's where is this really happening? Is this not really happening? Because the spread can happen undetected. And as we can see, because the spread can happen undetected and from an individual with no symptoms, the people that it can infect and the numbers, we certainly can see that they will rise, and the expectation is that we will have a high number of people that will die as a result of the coronavirus. And it's nothing that we've ever encountered before. So it's important just to understand that fact, but it is important to understand that as a community, as a country, that it can be contained, we can do it, we're seeing that we're doing it. We have measures that we can put in place, they're effective and they work. So what are the measures that we can put in place that we're always talking about now and we can see that it's working? One of them is hygiene. So I think that probably most people can say I've washed my hands more in the past 3 months than I have like sort of in my entire life. Not that you weren't washing your hands before, but there wasn't the concern to wash them as frequently. Maybe you didn't wash them as soon as you entered your home. Maybe you didn't wash them after having an exchange with someone at a takeout window. Maybe you didn't clean your hands immediately after that. But that important hygienic step is incredibly important. Wearing a mask is also incredibly important while we continue to battle coronavirus. Will we wear masks forever? Certainly not. But as long as the virus is here, and as long as we can see in our country that the virus levels or the people who are infected with the virus, that those numbers are rising. And remember, the big difference is people can be infected and have no symptoms. So when you wear a mask, you're not only protecting yourself, you're protecting primarily others. So a good personal example of that for me is I desperately, even more so than I want to protect myself, I want to protect my family. I also want to protect my patients. So when I go out, even if I thought that I was okay, I would never want to take a risk and not cover to make sure that I protected myself, so that then when I come in contact with my family members or my patients, that I could try to make sure that they're safe. So wearing a mask right now, I think is really important. Hoping that it offers me some protection, but I especially want to make sure that I protect others. The other thing that we're seeing right now, and we talked about this at dinner too, real life issues, is that things are really different now. And so this is a new normal, and we're doing what we have to do to stay safe. So stay at home when you can. If you don't have to go to work, you know, going out to grab a bite, bringing it back home, maybe not necessarily engaging in a lot of non-essential activities right now, and supporting everyone so that we can try to make sure that we contain our numbers as well. Super, super important concept. Okay, let's dive on in. So what can I do to protect myself and others, right? I elaborated a bit about that, and I'll take an even deeper dive. What can I do to protect myself and others? Again, there are 3 important things that you can do to protect yourself and others. And we're going to talk a little bit about an article from the New Yorker here at the end. But one of my favorite things in that particular article is where those 3 things really that we do in the hospitals or as healthcare providers that we put in place so that we can keep the rates of infection from healthcare provider to healthcare provider, or from healthcare provider to patient, or from patient back to healthcare provider. There are three important things. One of them is, again, hygiene. So I will never have those beautiful, I'm gonna date myself here for a second, I'll never have those beautiful Palmolive hands. It's never going to happen. And so my hands will probably indefinitely look a little alligator-like. And it's because of the very frequent and intense hand washing that I've done over almost a lifetime now. And so that one hygienic step of making sure that we wash our hands, not touch your face, rub your nose, touch your eyes, put something in your mouth, touch your mouth without making sure that your hands are very clean. And believe it or not, the average person may touch, your face up to 4 to 5 times in 1 hour. Yeah. 4 to 5 times in 1 hour. It's really, really hard to not touch your face, rub your nose, rub your eyes, rub your mouth. All of those things, if your hands are not clean, could be conduits. So from a hygienic standpoint, washing your hands and trying not to touch your face would be really important. Again, social distancing is important. I want to call it something else other than just social distancing. I want to call it social distancing pain or something. Because for someone who loves family and is a super extrovert, the social distancing is so difficult. Again, I don't think that this is something that will last forever, but it is important that we try to keep things as contained as possible. And again, that final piece, wearing a mask. Wearing a mask, especially if you're going to be indoors or if you're going to come in close contact within 6 feet of another person or other groups of people, is incredibly important. And we talked a little bit about this earlier, and it's one of the things that I share with my family and my children. So I've provided my family with education about why I think it's important to wear a mask. Again, it's very important for them to wear masks when they go in public situations, because not only do we have to keep our nuclear family safe, but then I remind them that I take care of patients. And so I need them to protect themselves on the outside, protect other people, and I also need to be protected. So in thinking about everyone else, wearing a mask is incredibly important. However, we also live in a judgment-free zone. If I think it's a poor decision for someone not to wear a mask in a crowded scenario or in a store, I'm trying not to pass judgment. Do I think it's a great idea? No, I don't. But we certainly respect other people's decisions. But from a medical standpoint, I would certainly advise you guys who are out there and listening, for now, until we can really gain great control over coronavirus, if you're out in public, wear a mask, clean your hands, and try not to touch your face. So those are the biggest things I think that we can do to protect ourselves and others from COVID. Did I cover that well? Dr. Buckner, anything you want to add?
No, you got it.
Yeah.
That's hammering it home.
Fantastic, fantastic. Okay, here's another very commonly asked question. Who's at higher risk for severe COVID infection? So being infected with COVID and having very severe life-threatening effects, right? And how can I help to protect them? So the protect part, I think we've kind of hammered it in. We wanted to share the CDC site because sometimes you're looking for places where you can go back and refer to something. And this is a great place, a reliable place to go. The CDC coronavirus precautions site. So there you can see who's listed in terms of who's at higher risk. So there are a few people who are at higher risk of severe infections with COVID, right? Severe side effects. Remember, what's unique about COVID is that we can have people that are infected with it and they may have no symptoms at all. So if those people, especially without a mask, come in contact with someone else who's high risk, you may have a bit of a situation. So in terms of age, high risk, people who are over the age of 65, and the website kept referring to older, and I joked around with Tyler earlier and I said, well, you know, what does older really mean? You know, is older 50, is older 60? Well, they specifically refer to 65 years of age because 8 out of 10 people who are over the age of 65 when infected with corona haven't really made it. So that's a really high risk group. Who else would be a higher risk group? People who have asthma fall into a higher risk category. People who are otherwise immunocompromised. So people who have an inherited condition and they're immunocompromised. People who are on medications post-transplant, post-cancer therapy, or any other condition. If you're on medications that sort of lower your immune system, people will be at higher risk. I think you've also heard of other kind of comorbidities, we would say. So other conditions that people have, if you mix that together with the age of 65 or older, anything else, high blood pressure, diabetes, obesity, pulmonary or lung disease, other things can certainly put you into that higher risk category. So again, patients who are over the age of 65, anyone who has, for example, something like asthma, if you are immunocompromised, meaning your immune system has been lowered because you either inherited a condition or you're taking medications that lower your natural defenses or your body's natural immunity, you are certainly going to be at risk for a more severe version of COVID-19, if that makes sense. So I hope that I laid it out pretty well. Did I leave anybody out?
No, but can I just clarify one thing, Tammy? I think I heard what you said correctly, but the 8 of 10 number, were you saying that of the people who have died, 8 out of 10 have been older, rather than not that 8 out of 10 people over 65 with COVID died?
No.
The other way around.
Yes.
It's just that the majority of deaths that have occurred have been in individuals who are older, and that's kind of how we understand that the disease affects the older population much more severely than their younger counterparts.
Absolutely. Thanks for clarifying that. And again, I think what I want to tack on to that is remember that many people, especially many young people, may have the virus and can still pass it along to others, manifesting no symptoms at all. Mm-hmm. So that's also an important fact to remember. Yeah. All right.
And you can have symptoms if you're younger, and it can be severe. It's just much less common.
Absolutely.
Let's have the next slide. So I'm going to talk now about some of the questions specific to those who live with inherited bleeding disorders. So next slide. So if I have an inherited bleeding disorder, am I at increased risk of catching COVID-19? And the answer to this question, as far as we know, is no, not by itself. The bleeding disorder doesn't affect the immune system directly, so that is not something that we have any reason to believe that those individuals are at higher risk. If, as Tammy said, you're taking an immune suppressant medication and you have an inherited bleeding disorder, then you would be at higher risk for a severe infection, but that's because of the immune suppressive medication and not the bleeding disorder directly. Mm-hmm. So let's have the next slide. Does COVID-19 impact the blood clotting mechanism, and how does this affect someone with a bleeding disorder? This is a very common question. It's a very complex question. The answer is changing as we learn. Again, this pandemic has only been around for a couple of months, and so the things we're learning change quite often. The general consensus at this point in terms of how it impacts the clotting system is that having an infection, and especially a severe infection, like one that puts you in the hospital, or especially one that puts you in the intensive care unit or on a breathing machine, in those situations, it looks like those patients are much more likely to be pushed toward the clotting end of the spectrum, meaning they're at higher risk for developing blood clots somewhere, like in the lungs or in a leg or arm, rather than a bleeding problem. This, in of itself, this kind of messing up the clotting system is not unique to COVID. It happens with other infections as well. There are some, but possibly unique features of the characteristics of the disturbance to the clotting system that are a little different for COVID. We don't know why that is, but it has been noticed in multiple settings that that's the case. The bottom line is that for somebody with a bleeding disorder, you know, having an infection, if it's severe, then just like anyone else, your care providers, your physicians, your nurses, your medical team is going to be concerned about the clotting system, and they're going to be keeping a close eye on it, because we know that in some people it goes a little bit haywire, and that requires more attention and care that's more intensive. So simply having a bleeding disorder doesn't make this any worse as far as we know, but it does make it a bit more complicated. If we're working to essentially correct your clotting system by giving you clotting factor, for example, then that's just another layer to the management of this problem. So the bleeding disorder itself, again, is not part of the problem, but it is part of the equation and something that we have to kind of take into account. And again, multiple groups of hematologists and other providers who are way smarter than me have been really trying to pull together as much information as we can get as quickly as possible to really to understand this better, because it is an issue that we are watching very closely.
And if I can just piggyback a couple of things, you know, onto that, too, Tyler, you know, especially highlighting when you mentioned that as a community of hematologists that we're collecting information so that we can learn and understand what's happening specifically with people with blood disorders. NHF also has a community platform with My Blood Disorders, and within that community platform, there's also survey information that's being collected, and that's being looked at right now in terms of what's happening in the community to folks who are either infected, exposed, have had severe illness, mild illness, COVID positive. So a lot of that information is being collected for you as a community via NHF. The other thing that I'll just kind of piggyback and highlight, and maybe say in just a slightly different way, is your hematologist, us, myself and Tyler and our community of hematologists, most of us are very well trained and have had significant experience in caring for very severely ill patients, especially patients that are severely ill, even with bleeding disorders. And so understanding the clotting system, the bleeding system, and what your needs are, especially if you are in an intensive care like setting, if you have very severe illness of any variety, including COVID-19, we have the experience in globally managing that, even if we don't have the experience specifically with this particular infection. So it is important, if you are a member of the bleeding disorders community, that if you're severely ill, that you're in a place where you have an experienced hematologist who understands bleeding disorders to make sure that you have appropriate care, because we do know that this can happen. So just said it in a slightly different way, I suppose.
No, I totally agree. And we rely on our network of friends and colleagues to help each other too. So it's not like just one of us on an island. I'm calling my friends all the time if I have issues.
Yeah.
So the next question, should I change my treatment or prophylaxis regimen because of COVID? The short answer to this is no. There's nothing to say that your standard of care treatment for your bleeding disorder needs to change at all because of the pandemic. So we'll move on to the next slide. What happens if I have to go to the hospital, and what should I do? So again, this is we have certainly seen a change in the patterns of what people use in terms of a threshold of deciding when do I go to the hospital, and so that in of itself is a difficult question, and obviously depends on your situation. So I think we would reiterate the importance of communication and just staying in touch with your providers, your hematology clinic, your hemophilia treatment center, hemophilia and thrombosis center, because they can help guide you. If you do have to go to the hospital, just like we say across the board, wear a mask. Many hospitals, depending on the level of community spread and number of cases of COVID that they're seeing, will have very restrictive visitor policies. I know that my hospital allowed 0 visitors for a number of weeks and have only recently relaxed that to allow occasional visitors. So be prepared for that. Your family member may not be allowed to go in with you. If you have a phone or another means of communication, take it with you. Make sure it's charged. If it's not charged, take your charger, so that you can communicate. I think we've all seen that from the hospital's side of things, we know that these policies are really difficult for a lot of people and a lot of different reasons. And so we try to help accommodate as much as we can communication needs and helping keep families up to date, even if they can't physically come in. But if you do have to go to the hospital, wear your mask and stay in touch with your bleeding disorders treatment providers.
And can I just add a couple things? Like, since unfortunately I actually just had to go to the emergency room not long ago myself with an issue, and kind of got to firsthand see, what happens when you go into the emergency room. I think very early on with the infection, we were trying to get the word out that if you didn't have something that was, really serious or really critical, that you maybe not go into the emergency rooms, you not visit the hospitals. I want to make sure that the message is don't go to the hospital. That's not the message. The message is certainly if you have any concerns that you feel need to be addressed urgently, absolutely don't hesitate to go to the emergency room. One important thing that Tyler mentioned was go to the emergency room, but in the bleeding disorders community, communicate with your hematologist. Communicate with your team so that you can have a team player that's kind of directing and participating if at all possible. The next thing is when you go into that emergency room or hospital, and again, as he pointed out, you're going alone, the hospital staff is very sensitive typically to the fact that you're going in alone. And at least for me, they were very helpful, offered a charger, for my phone so that I could communicate. No one balked at me using my cell phone, texting, calling, FaceTime. So they're very supportive with that. Additionally, the rules are a little different in pediatrics. So in pediatrics, children, of course, don't go in alone, but you can't go in with 2 parents. You would have to tag team. One parent is allowed typically during this COVID crisis to go in with a PEDS case or a pediatric patient or a child.
That changes too. We just relaxed it to 2.
Awesome. But wear your mask. Gotta wear your mask.
Wear your mask. Wear your mask. All right, next question. How can I make sure my bleeding disorder is known to my doctors in emergencies? We included this slide really just to take a moment to say, speak up. You have to be empowered to advocate for yourself, to advocate for your child, and say, hey, this is something that I deal with, and you need to know about it. And my doctors, nurse practitioners, PA, whoever is taking care of you from a bleeding disorder perspective, they need to know that you're there and can, so that they can contribute. There are simple things that we all kind of recommend to our patients all the time, like medic alert bracelets, putting in case of emergency entry into your phone, so that first responders can find that. Having a wallet card if your center uses one of those, and giving those or copies of those to the emergency room staff as soon as you get there. That's hugely important, so that they have a good picture of what they're up against and what you're up against, so that they can provide the best care possible. We're going to move a little quicker because we got a bunch of questions. Thanks, Lynn. Next slide. Will coronavirus affect home delivery of the supply of my treatment? Again, this is something else that multiple people, multiple groups are keeping a close eye on. There's no indication that this is the case at this point or in the future. Be very reassured that NHF, along with other groups, is very attuned to this issue. And so, keep your eyes and ears open for messages from NHF. But so far, everything has been fine with not disrupting the supply chain. I know the healthcare system is under pressure. Should I still contact my HTC if I have a problem? Of course, we've said that multiple times. I would encourage you to be patient. I know that we've upset a few patients here and there because of our timelines, and it is slower than things usually are. It may take us a little longer to return that call or to get you a routine appointment. But we're working on it. So be patient, but do contact your HTC definitely. Next slide. All right, now we're getting to the inhibitor specific stuff, which I'll switch to Tami.
Awesome, thank you. Okay, so I am going to kind of power through some of these questions because you guys have additional questions, and that's what this is all about, to get to your questions. So we have some of these commonly asked questions, so I'm just gonna go through them really quickly and again, kind of quickly get to the point. So if I have an inhibitor, am I at increased risk of catching COVID-19, or I'm gonna add, of having a more severe reaction just because I have an inhibitor? Right? The answer to that across the board is no. So just because you have an inhibitor does not mean that you're immunocompromised. However, if you have received medications, remember I said that initially, if you receive medications, and I'll throw a couple out there, anything that lowers your immune system, so steroids would be included, rituximab, cyclophosphamide. So there are lots of immunosuppressants that are out there. Cellceps, the tacrolimus of the world. So if you've received those medications, then the answer would be yes, but not just because you're a patient with an inhibitor, okay? All right, next question. Okay, so do we understand what would happen if a person with a high responding inhibitor contracted COVID-19? This came from a mom. Historically, when my son would get any fever or cold, his inhibitor would rise. Should we take extra precautions to keep him from getting COVID-19? Okay. So should you take extra precautions? Yes. But everybody should take those extra precautions, all of us. So the precautions that you should take as the mom of a patient with an inhibitor shouldn't necessarily be any different. We should all take those precautions of hygiene, mask, social distancing, and trying to keep our family safe. With any infection, it could be a line infection, a bacterial infection, a urinary tract infection, an ear infection, a cold, anything. If you have a high responding inhibitor, then yes, you'll see those numbers go up. Does it change what we do to treat in terms of bleeding, bleeding prophylaxis, bleeding episodes? If your inhibitor level goes up, if you're a high titer patient, no, it wouldn't. But is it important to take those extra precautions? Absolutely. But there's no difference in the immune system, otherwise, if that makes sense, okay? And I'm happy to elaborate on that if we have some more time at the end. Let's go to the next question. I've heard that if you're on Hemlibra and you get COVID-19, it can form blood clots. Is this true? So the real answer to that is we don't really know exactly, because we haven't had a ton of patients that have had COVID-19 who are on Hemlibra. However, I would go back to what we said in the beginning. Should you change your prophylaxis regimen just because we're in the middle of a COVID-19 pandemic? Absolutely not. We're not recommending that at all. Have we seen many patients on Hemlibra and having additional clots? No. If you are any patient on Hemlibra as prophylaxis, on factor prophylaxis at all, and you have a very severe form of COVID infection, is it possible that you could have clots and it separate and apart from whatever prophylaxis regimen you're on? Absolutely. If you're a patient with a bleeding disorder on Hemlibra, not on Hemlibra, on anything, should you be cared for by an intensive team that includes a hematologist that is very familiar with bleeding disorders? Absolutely. Right? But no, that's not true. Okay.
And I'll just add, we talk about this a lot because it is very much unknown. What we do know is that it's quite complex to, again, we talked about the added layer of complexity when you have an inherited condition and you happen to have COVID-19 at the same time. This being on Hemlibra is just another layer. It complicates testing for coagulation or the clotting tests that we do. And so the person's taking care of you just need to be able to understand that so that they know how to interpret those tests and know the right tests to do. And so that, again, it's just another reinforcement of if and when it becomes necessary to, have intensive monitoring, you really want to have a team there that kind of understands the implications of this particular drug, because it is it's still new in terms of the grand scheme of things, having been around on the market only a couple of years. So yeah, having the right team involved is important.
And I would underline that 5 times. Yeah, having the right team involved. Okay, how serious is the increase in blood clots with patients who have contracted coronavirus while taking Hemlibra? Again, I wanted to make sure that you had a chance to see this because this is a question that a lot of people have. And I think that we've, sort of addressed that, right, already. The team is very important in terms of taking care of someone who just so happens to have a very severe infection if you happen to be on Hemlibra, but that same thing would apply if you're on any prophylaxis, but especially understanding the testing differences with the Hemlibra and having the right team involved is always going to be key. And we're still collecting information about what happened, so there are a lot of unknowns. I have an inhibitor myself, take prophylaxis on Hemlibra. Does this make it safe for me to return to work at the grocery store where I work? And so again, I'm going to go back to those 3 basic principles that I talked about. Wearing a mask, really staying on top of your hygiene, including hand washing and not touching your face, and keeping that social distancing there. Those things are going to be really important for all of us. And remember, just because you have an inhibitor does not mean that your immune system is somehow different from someone who does not. I'm debating if it's safe to return, severe hemophilia A aside. I'm with you on that. Addressing some of those fears and concerns, is it safe to be in the workplace? Again, it's sort of an example would be, as a physician, like my workplace has never kind of turned off. I have to walk into the hospital. I have to go into the hospital. I have to go into the office. We have to see patients. We have to remain engaged. But we're doing that exercising precautions, right? We're using that hygiene, using the masks, using the social distancing when possible, doing everything we can, including not going out. I don't know if I ever went to the hospital just because, maybe I did sometimes, but I don't know. But going out, doing things only when I have to at this time. So very fair question. All right.
Yeah, I would say make sure your employer supports those measures and
Absolutely.
Not just you implementing them for yourself, but also everybody you work with. I mean, do they require that people wear masks, that customers wear masks when they come in? Are your coworkers required to wear masks and wash their hands and stay 6 feet away? And the more that your employer's involved in making that an across the board, the safer the situation's going to be. And that, that is at some levels a very local decision and not something that is mandated from above. So you really just have to check, I think, what your local situation is and make a judgment based on what that is. And it like Tami said, I agree. It's not so much that you have hemophilia or that you're on Hemlibra, but more that what is the true uptake of those preventative measures. There are many places with essential workers outside of healthcare. I think healthcare has been much more aggressive in many cases with all these kind of preventative measures that Tami has talked about, which is why we've seen some relative success in terms of low numbers of transmission or infections in our healthcare workers by and large. But in situations where those measures are not as stringent or strict, it's not been as successful. So it does depend on it. And I'd encourage you just to talk to your employer about it and see what they say.
And you know what, that reminds me to say one thing, because that's so important about talking to your employer. But not only talk to your employer, if you have questions about this, specifically about your individual situation, you know what, talk to your employer and take that information back to your HTC. Talk to your hematologist, kind of bounce it off of them to get some reassurance on how you should proceed as an individual. I think that's really important. And by the way, I think a grocery store worker is essential personnel.
Oh yeah, I have been from the beginning.
You are essential personnel. So yeah, have that conversation. Okay, I think real quick, if I'm HIV positive, am I at increased risk? What if I have chronic hepatitis? So just because you're HIV positive, no, it's not a significant risk. However, if you have a very low CD4 count, so meaning if you, by definition, have had an infection that people have when you're severely immunocompromised like PCP pneumonias or skin infections, and you have AIDS by definition, because your T cell count is so incredibly low, typically, especially below 200, you would need to know that information, and yes, you would be at risk. But outside of that, no. Chronic hepatitis all by itself, no, unless it's associated with some other conditions. However, chronic hepatitis is one of those pre-existing health conditions that, when you combine that with other things, including COVID infection, could be one of those comorbidities that could result in a more severe infection. Okay. All right, I'm worried, what should I do? Here's that link to that great article that I alluded to earlier. Take a look, but let's see if we have time to get to some of your questions that you've typed in, right?
Yeah, thanks, Dr. Singleton, Dr. Buckner, Dr. Valentino, we appreciate it. And we did have several questions that did come in. I think it's okay if we go a little bit over time tonight. There's a lot of great information here. So first question is, how accurate do you think the rapid antigen and antibody tests are? I think I may have had COVID-19. Should I have the antibody test now?
I'll jump in. That varies depending on the test. In most places, the terms we use are sensitivity and specificity, and that means how likely is the test to be positive if I have it, or is the test to be negative if I don't have it. And in general, the tests that are available are pretty good. There's a few notable exceptions that I've heard, that have been reported on with much lower numbers. The key, though, is that even the antibody test is not interpretable at the moment, because we don't know that if you have these antibodies, we don't know if they're protective. We don't know for absolute certain that they're specific to this coronavirus. It could be a different coronavirus that caused you to have the positive antibody test. We're just not sure. And it's important that those tests are being done, because that's how we learn whether the antibodies are protective for people, but we're not going to know that for a long time. So, where I work, people are now, employees can get the antibody test. I got it done. But it's very clearly stated, no matter what the results are, it does not change anything about, all these other precautions and how you decide whether you come to work or not. If you're sick, you don't come to work, even if you've got evidence of a past infection. It doesn't matter, because we don't know for sure exactly what they mean.
And can I piggyback onto that? Absolutely ditto, agree with everything Dr. Buckner said. He said it so incredibly well. I will just add that with every test that we have in medicine, there's that sensitivity and specificity, right? So you can have some false positives, you can have some false negatives. And for sure, to just straight up answer your question, is it possible that we could have that with this antigen testing or this antibody testing? Sure, that's possible. But I think it's very important to remember, specifically with the antigen testing, that if you have symptoms and your coronavirus antigen test is negative, act like you have coronavirus. Just act like it. You know, quarantine yourself, assume you have coronavirus, you know, don't go sharing, even if we don't know what you have, but it could really be coronavirus. Even if that test was negative, just go ahead and act like it. At the same time, it's very reasonable to believe, right, with what I laid out before, we certainly know that you could have coronavirus with very minimal symptoms. So if you have very mild symptoms, some people only have loss of taste, you know, or smell. If that's you and your coronavirus test was positive, believe it and just go ahead and act like you have coronavirus. Now, my take on the antibody testing, I think that's going to be very important moving forward for us so that we can understand what that means. And as Dr. Buckner mentioned, we don't necessarily know what that means. And just because you're antibody positive certainly doesn't mean that you're now going to be protected. But I haven't had the antibody testing, but I'll be kind of transparent and share with you. I intend to have it, not because I think that it will give me a sense of security in terms of protection, but maybe if I'm positive, maybe I could donate plasma to help somebody, or maybe it will help them as they are developing vaccines to understand that titer and that immunity moving forward. So I'm not really sure what it means. Okay. Next question, what you got?
Perfect, thank you. So next question is, as we're seeing the country slowly reopening, I'm worried about schools in September. While I know I will not be able to shield my child forever, my son will be a sophomore in high school next year, and I'm very reluctant to send him. In the case in-person classes have started. He has hemophilia A with inhibitors, and that also piggybacks on another question here I think you can answer in the same section, is my 5-year-old son has an inhibitor and is on immune tolerance. Should I send him to school in the fall?
Man, can I be honest? I'll hop in, Dr. Buckner, here for a second. Can I just be real honest and just tell you, I'm going to be real raw, transparent, vulnerable, all that, and just tell you, I almost want to plead the fifth, you know, when you ask the question, because I have a child who's starting her freshman year in college in the fall, and I have 2 children who, one is in middle school and one is in high school. It gives me palpitations, just kind of as a mom, just kind of thinking about it. So I'll just pass along from a practical sense what I'm doing and what I'm thinking, and then I'm gonna see if Tyler has something from a logical standpoint to help all of us reel this in. Not to put the pressure on you, but I am going to wait to see, because things change week by week and month by month, right? So I am posturing myself to wait to take the lead from our city, government, officials, the schools, who I know have our best interests at heart, looking at what's happening at the time. I'm trying to keep myself open to all of the suggestions that could possibly be made. At the same time, and listen to this, it's real important, that you kind of reel in some of your anxiety and the feeling that we have because we don't have control, like we've lost this. I know it drives me insane. And just know that we're not going to be comfortable with any of the decisions. I'm not comfortable with keeping my kids at home and they can't go to school. I'm not comfortable with my freshmen not being able to go away to college, but I'm also not comfortable with her going. And I'm also not comfortable with my kids going to school. So I know I'm not comfortable with any scenario, right? So I'm gonna just wait and see what we're dealing with as we come closer to that time, understanding that we are all in this together. It's not just you, it's not just me, we're all in this together. So I think we have to wait to see what the recommendations are going to be and where we're going to be come late July, August, and we have to make decisions. So there are lots of models and lots of things that are being thrown out there. I know that school systems, colleges, universities are all kind of looking at different models. Some people have made decisions already about what they're going to do or not going to do. I just think we have to wait. Do you have anything?
I would agree. First of all, we all feel that anxiety, all
Yeah.
of us, you know, whether we're parents or not. And I'm with Tammy. There's a lot that we don't know about next week, much less a few months from now. So I think remaining situationally aware again is important. Knowing what's going on in your local community in terms of levels of spread, being aware of how in touch your local government and school systems are with those recommendations from public health and other health officials. You know, I think the final thing to say is that simply having an inhibitor, even being on immune tolerance induction, I don't think makes it changes those decisions. You know, you have to base those decisions on all those other external factors, but having hemophilia, having an inhibitor, again, as far as we know, does not increase your risk of catching this or necessarily the severity of the infection, particularly in a child. So I don't think that necessarily is the deciding factor. It's more all this other stuff, which we just don't know how it's going to look in 3 months.
Right.
So you have to just kind of stay in touch.
And talk this out with your team. You know, talk it out as you get closer to that time. You know, kind of sit down and have a conversation with someone who really knows you and knows your situation and is as well kind of aware of what's happening in terms of the whole COVID crisis. So.
Great. Great. Thank you. This flows nicely into the next question here. I understand about the higher risk with older people, but do we really know it's less common for children, since it sounds like they present different symptoms like Kawasaki disease or cardio issues?
Mm-hmm.
Are young patients with those symptoms being recorded as COVID patients?
I'll hop in and kind of say what I know. I think that there's a heightened sense of awareness now in terms of testing for COVID, for coronavirus, especially with a child who's presenting with any severe illness, whether it be kind of typical coronavirus or not. I think that, so the testing, I think, is going to be there. In terms of bigger numbers and understanding exactly what was happening in the pediatric population and younger children, I think that we're doing a good job in terms of at least recognizing this Kawasaki-like or Kawasaki phenomenon. And for those of you who don't understand what that is, Kawasaki's disease, and specifically in children, we think is a response of a child's kind of inflammatory system to some previous illness. So it could be any other viral illness. Now it just so happens to be coronavirus or COVID-19. And so it's a body's kind of exaggerated or hyper response to the presence of infection. And it can cause a child to have cardiac or heart issues, as well as other systems involved from a severe inflammatory standpoint. We're now recognizing that that's happening in children who were previously asymptomatic or had very mild symptoms, but we know that it is now, we now know that that presentation, that Kawasaki-like presentation, was related to coronavirus or COVID-19. So we're recognizing it, it's being tested, it's being picked up. What are going to be the long-term consequences? How many children will be affected? In terms of that inflammatory response or hyper response, we don't necessarily yet know, but at least we're recognizing that phenomenon. Tyler, you have anything on that? Because I think that's important too.
Unfortunately, Dr. Buckner had to step away, but Dr.
Okay.
Valentino, if you have any, Len, if you have any anything you wanted to add to that?
No, I think Tammy covered it sufficiently.
Great. All right, next question is, can you talk more about the disease we're seeing in young kids, the multisystem inflammatory syndrome?
Yeah, so again, so this multi-system inflammatory syndrome is like a cousin, again, to something that's very familiar to us in pediatrics called Kawasaki's disease. And typically we would see this in response to a previous viral infection. Sometimes the infection was known, sometimes it was unknown. Sometimes we could identify previous symptoms, sometimes not. It sort of makes sense that we may see this phenomenon associated with coronavirus or COVID-19. It's typically associated with high fever for more than 4 days. It can also be associated with very large lymph nodes, so your body's inflammatory system is really kind of driving up the organs that help you to fight infection, and now everything is very inflamed. The spleen can be very big, the liver can be very big. You can also have antibodies that sort of attack some of the heart tissue and can cause weakening in some of the blood vessels there. We typically see that in a Kawasaki-like phenomenon, and that's one of the things that can make it so risky. You can even have kidney involvement. And so that systemic, that body's hyper response, that hyper responsiveness that we see post-infection is something, again, that we're familiar with in pediatrics, and we're now seeing it in relation to coronavirus. Is it important that if that phenomenon is starting, that a child be seen by a pediatrician? Absolutely. It is very important. So what to do if there's high fever for a number of days or any other significant changes in a child's overall behavior over a course of days? Please make sure that you're communicating with your general pediatricians or communicating with your hemophilia team. It's really important to get some direction on what the follow-up should be. And I think that my colleagues and I are doing a really good job in terms of following up those PEDS cases when we suspect that something is going on. So there's a heightened sense of awareness.
Great. Thank you, Tammy. We'll get to the next question here. We got 2 more left.
Sure.
Do you recommend gloves and glasses in addition to masks, especially when you make a visit to the ER?
Yeah. Okay. So this is, you kind of tapped into like one of my little pet peeves here I'll have to share with you. So I think that certainly we use gloves in healthcare, right? And gloves are important. But I want to ask you one question as an example. In healthcare, when you see us using gloves as a barrier, right, to make sure that we're protected and to make sure that a patient is protected, you will never see me, for example, I'll use myself as an example, coming in with my clean hands, putting on gloves, touching you, examining you, and then going to the doorknob with those same gloves on, going to touch the light switch, going to the bathroom, answering a phone, or going to the computer with those same gloves on. So yes, gloves can serve as an excellent barrier, but they need to be used for a single activity if you're not going to cross-contaminate surfaces. So if you want to use a pair of gloves when you go to pump gas, and then you carefully take those gloves off and dispose of them appropriately and then clean your hands, I see nothing wrong with that. If you want to go put on gloves to go pick up tomatoes, in the grocery store, I think that's, totally fine. Put them away. But to go in the grocery store, to go in any store, touching on, all of the different surfaces, going and paying and everything else with a single pair of gloves, from a bacterial or viral or infectious standpoint, you're really, really kind of defeating the purpose. And now your gloves have become what is referred to as a fomite. It is carrying the surface of, on the surface of it, you're carrying bacteria, viruses, and everything else. Now, instead of it just being on your hands, it's all over these gloves and everything that you're touching. Touch your phone, touch your bag, touch all the other things. So if you're going to use gloves, just try to make sure you use them for a singular purpose. What would be better is that you make sure that your hands are clean as much as possible. So if you go into the grocery store, and I did this actually before COVID, if I went to the grocery store, I have hand sanitizer on the door of my car. Before I touch anything in my car, what am I going to do? I'm going to clean, my hands as much as possible before I touch my steering wheel, before I kind of get in. Making sure your hands are clean is superior to wearing gloves and not using them appropriately. So I hope that part makes sense. in terms of wearing glasses, unless you're really going to come in close contact with someone, I don't necessarily think that glasses or any eye protection is completely necessary. And I'll give you maybe another concrete example of that. Again, in my examination of patients, I still see patients. I see patients in the hospital. I may want some eye protection if the patient doesn't have on a mask when I'm getting close to examine them. I'm always at significant risk if I don't have on eye protection when I'm going in to look into a mouth, a throat, and that person could potentially kind of cough, directly in my face, which I want to tell you that as a pediatrician, that has happened many, many, many times over the course, of my career as a pediatric hematologist. So now that I'm in, a kind of COVID-19 pandemic, if I'm in a situation and I need to go in and look at a throat, or I need to go in and do an NP aspirate to test for COVID, do I need something to cover my eyes to protect myself? Sure, I do. Outside of that, even I don't need it, and I don't think that you necessarily need to have it. But hey, listen, if you want to put on some cool sunglasses to go outside and go to the grocery store, knock yourself out.
That's great. That's a great perspective, Dr. Singleton. Thank you for that. And one last question here. It's a short one, but it says, can COVID-19 form blood clots?
Yeah. So here's the thing. Because this is an important question. You guys are right to be concerned. So I just want to make sure that you understand this, very clearly. So anytime you are infected with a virus, a bacteria, or anything, even COVID aside, and it is severely and intensely affecting your system, people have issues with clotting. Okay? Whenever there's a severe infection going on, we are always battling microscopic clotting. Sometimes macroscopic large clots. We're always fighting that phenomenon. You are now aware of it because we're now talking to everyone about what happens with coronavirus COVID-19. But I want you to be aware of that fact. Many times with anyone who is severely infected with any severe bacteria, sepsis, bacteremia, any horrible virus, and you are very sick in the ICU, especially patients who are intubated and requiring lots of support, we always battle and fight microscopic or macroscopic clots. We're always fighting that. What we are noticing, and it's important for us to notice, is that we are also seeing this phenomenon in patients that are infected with coronavirus/COVID-19, so that we know how to maybe get in front of this from a prophylactic standpoint, maybe be more aggressive in looking for clots, it's a phenomenon called DIC, microscopic clotting, really being on top of laboratory results, because we know that this phenomenon can also be associated with this particular viral infection. So I just wanted to give you that kind of historical reference that this is not necessarily a new phenomenon, but it is important as a medical community that we understand that it can also happen with COVID-19, which ties us right back to when Dr. Buckner and I were kind of talking earlier about how important it is if you have a bleeding disorder and you are severely ill, that you have to and should have a hematologist who cares for patients with bleeding disorders on your care team. It's incredibly important. And for that reason. Okay. All right.
Thank you again. We appreciate that. And doesn't look like any more questions are coming in. So I'd like to thank all of our panelists for taking the time to join us this evening. We appreciate your time and expertise. And I'd also like to thank each and every one of you for joining us. Please note that this recorded webinar will be available on Monday, June 1st, at the COVID-19 section at hemophilia.org. You'll also be able to find this information in the next weekly issue of our Health and Wellness e-newsletter from the desk of Dr. Valentino that will hit your inboxes on Thursday. Thank you for joining us this evening, and remember, we are here for you. Thank you.
Thank you, everybody.